Imagine you're sick, just a little sick. It's not bad though, you can muddle through it. You have responsibilities and timelines. You can't slow down for a little cough. But then the next morning, you're feeling worse. You're coughing up so much phlegm that by the afternoon your muscles are worn out from coughing so much. It hurts to breathe. You're so weak you can't even make yourself a meal. You're starting to feel that you can't even catch your breath. So you call your friend to take you to the hospital, and the next thing you know, you're on a hospital bed. Nurses are all around you, opening medical equipment and assuring you that you're going to be just fine. The doctor says he wants to put a breathing tube down your throat to help you breathe. Mercifully, the sedatives unplug your mind and you're whisked off to sleep. When you wake up, you're in a semi-awake state. You're not quite awake, but you're not quite asleep either. Your first impulse is to reach for your throat, which is dry and painful, and you quickly discover that your wrists are tied by cloth handcuffs to the bed that you're lying in. You have the breathing tube in your mouth, and it hurts to swallow, and you can't talk. All around you are machines, monitors, and plastic gadgets, tubes, and weird alien-like devices that you've never seen before. Next to you is a machine that's connected to the tube in your throat, and you realize that this machine is the only thing allowing you to breathe. You have so many questions. How long have you been here? Does your family know about this? And where are they? How much is the bill going to be for all of this? And above all, are you going to live? I mean, how sick are you anyway? Although you're only half awake, you can see the doctor staring at you from the door of your room. He looks like he's about 20 years old. He's talking to a young blonde woman in scrubs. A nurse, maybe? Oddly, although your entire scene in the mind is hazy and dreamlike, you somehow managed her name tag, and it says respiratory therapist. The doctor and the respiratory therapist are discussing something, nodding their heads and gesturing toward you. Then the doctor says something to the respiratory therapist and walks away. The respiratory therapist walks up to your ventilator. The machine that's keeping you precariously alive reaches for the screen, and she's about to do something to your breathing. What's she about to do? Does she know what she's doing? With no voice and no friends or family here, you can only hope that she does. Good morning. My name is James Inciardi. I'm a registered respiratory therapist currently working at the VA hospital in Aurora, Colorado. This module is designed to teach you about ventilator-induced lung injuries and ARDS. According to research, mortality rate for people with ARDS is between 30 and 50%. As respiratory therapist, it's going to be up to you to help these patients get better. The physician will have orders, and you're going to have to know why they're making these orders. Does the order make sense? What if the physician you're working with doesn't know a lot about how to treat ARDS? Well, then it might be up to you to advise the doctor on the best course of action. The patient's life may depend on your knowledge. By the end of this presentation, you should be able to identify ARDS on a chest X-ray, describe the 3 types of trauma at work in ARDS, and describe at least 3 treatments in ARDS, and when they're used and how they work. But before we get into the heart of the matter, let's start with this. This is a really important paper by Ashworth and colleagues. It's the first paper to describe ARDS. This was back in 1967, and at that time there was a few different names for ARDS. Sometimes it was called Da Nang lung because of the Vietnam War was happening at this time. It was also called adult respiratory distress syndrome. But anyway, to summarize this article very briefly, Ashworth discovered that by applying PEEP, these patients' conditions improved dramatically. And he almost discovered it by accident. He had a 19-year-old patient whom they did not expect to live. They were using a ventilator that was just an old ventilator that had been locked in a basement for a long time. And he flipped the switch, and he didn't even really know exactly what it did. But it turned out to be PEEP, and he noticed that when the switch was on, the patient's status improved. And the patient survived, by the way. It was a really interesting and historic paper. Now, when you think of ARDS, or how it starts, you're looking at two ways that it can start: primary and secondary. As you see from the slide, primary ARDS happens from a direct insult to the lungs. Smoke inhalation, for example, will cause primary ARDS, near drowning or pneumonia. These are direct injuries to the lungs. Secondary ARDS happens when a disease from another part of the body infects the lungs. Usually, when there's a really serious infection in another organ of the body, if it's bad enough to affect another organ of the body, that other organ will be the lungs. I almost think of it as the lungs as a net for biotrauma. If other organs are going to release cytokines into the bloodstream, it's the lungs that will show it. Now, recognizing ARDS is extremely important. Here are the features of ARDS. First, ARDS has to happen within a week of the known clinical insult. Sometimes you'll see people who have lungs that look like this, but they're chronic problems. And we're not going to treat someone with chronic problems quite the same way as we treat someone with acute problems. Second, we are going to look for bilateral, fluffy white opacities. Bilateral, fluffy white opacities. Now that's important. If you say that exact phrase, then other RTs and doctors will know exactly what you're talking about. This is a key phrase. Bilateral, fluffy white opacities. Third, they don't have a disease process that's explained by cardiac problems. If someone has heart failure, for example, well, cardiogenic pulmonary edema can mimic ARDS. So, after you conclude that the patient meets this criteria, you have to calculate the PF ratio. That's right here on the slide, right over here. Now, based on that calculation, you have mild, moderate, or severe ARDS. Now, even though the PF ratio is dependent on oxygenation, hypercapnia is equally important because it indicates impending respiratory muscle fatigue. You might have to intubate anyway, even though oxygenation is adequate. Now, next, I'm going to show you a bunch of chest x-rays, and I want you to be able to see if you can tell which of these chest x-rays are ARDS. Remember, the hallmark sign of ARDS on a chest x-ray is fluffy white opacities, like the ones that you see here in the upper left. If it doesn't have those fluffy white opacities, it's not ARDS. And some of the lungs in these pictures are sick, but if they don't have the fluffy white opacities, the bilateral fluffy white opacities, then it's not ARDS. Also, look at the normal chest x-ray here. You see the hilum right here, and over here. That's normal. Those are not fluffy white opacities. So if you see those, that's not ARDS. That's supposed to be there. In these next slides, you're going to be shown 6 chest x-rays, and some of them have ARDS and some of them do not. See if you can spot the ARDS lungs versus the non-ARDS lungs. Remember, you don't have to know exactly what the x-ray is showing, you just have to know if it's ARDS or not. But before I show you those slides, let me show you this one right here. Because you might want to know just what are those fluffy white infiltrates? Well, that's why I put this picture in here. And this is not going to be the last time you see this picture. I'm going to get more in depth with this picture later. So you see slides C and D on the right there. This is ARDS. And you see the slides A and B on the left. This is not ARDS. You see the difference, right? So when you see the fluffy white opacities, you're going to be seeing, what you're seeing there is inflammation. You got that? Okay, now I'm going to get back to this picture a little bit later on, but for now, let's get on with the chest x-rays, okay? Is this ARDS? And yes, this is ARDS, okay? The next one is right here. Is this one ARDS? And no, this is not ARDS. This is a normal chest x-ray. This is the high limb. Remember, if you got fooled by that, it's okay. These are normal though, all right? Okay, next is this one. Is this ARDS? Well, this is not ARDS. It is something. It is actually a pneumothorax. You can see the lung right here, how it's not inflated there. See that? Big pneumothorax. Okay. Next is, how about this one? Is this one ARDS? And we see the fluffy white opacities there, so yes, this is ARDS. Okay. Right. Next is this one here. Is this one ARDS? We see the left lung is completely whited out almost. No, this is not ARDS. This is not fluffy white opacities. This is a pneumonectomy. Okay. That means somebody had the left lung removed for one reason or another. Okay. Next is this one here. Is this one ARDS? And yes, it is. This is ARDS. Okay. Now, let's talk about the mechanism of damage with ARDS. The lungs are damaged by three forces. One force that causes this damage is Adalec trauma. That refers to when the lungs are opening and closing. In the setting of lung inflammation, this causes a lot of strain and stress within the lungs. With increased volume, you get increased pressure, which causes excessive strain and rupture of the lung tissue. And the next one is biotrauma. The main pathological cause for both heterogeneous ventilation and altered alveolar and small airway mechanics is airway flooding with edema and the accompanying loss of surfactant function. As edema spreads, it deactivates surfactant, which causes more alveoli to become edematous, deactivates more surfactant, and so on. Volutrauma is another mechanism of injury, but not as much as biotrauma and Adalec trauma. Which one causes more damage between Adalec trauma and biotrauma? Well, they're both pretty severe, and I've found literature that says different things. One says biotrauma, the other says Adalec trauma, so I'm just going to say that they're both pretty substantial. Volume trauma is another factor, but not as much as Adalec trauma and biotrauma. Okay. Now let's get into the ARDS phases. There's two phases, or hits. The first hit is the exudative phase. That's what we mainly deal with. That's the phase that has the characteristic inflammation and trauma and so forth. The second hit is the proliferative phase, and we don't see that as much anymore. I'll talk to you about the exudative phase now, and we'll get into the proliferative phase a little bit later on. This picture comes from one of my favorite studies by Hibachi and colleagues. What they did was they took these pigs and they gave them a disease process that would normally give them ARDS. Then they ventilated them before the ARDS set in. They ventilated them with low tidal volumes, or ARDSNet. If you don't know what ARDSNet is, don't worry, I'll get into it later. But briefly, it's low tidal volumes. They ventilated some of them with ARDSNet and some of them with another mode called APRV. And the characteristic there is it gives a lot of PEEP. And this is what they got. As you can see, pictures A and B, these lungs are in pretty good shape. These lungs were ventilated with APRV. Well, pictures C and D are red and inflamed. These pictures in C and D are experiencing the exudative phase. They were ventilated with low tidal volumes, or ARDSNet. We can see that the inflammation and the white exudate coming out here. You see white exudate here, here, here. Yeah, and look how red and inflamed it is. You can see that. And you can see, this is when you look at the chest x-ray and you see those fluffy white opacities, this is what the lungs look like. Also note here that I've underlined and highlighted that surfactant is rendered useless, and that's important. And I'm going to explain that to you right now. Here's why surfactant is so important. You remember how surfactant allows alveoli to open and close more easily. Well, in ARDS, the surfactant is not working. As you can see, the area around the H is your collapsed alveoli that will not open. The asterisks represent alveoli that are overdistended. They're being pulled in two different directions. In one direction by the alveoli that are not opening, and the other by alveoli that are opening. So they're being overstretched. This is what we call heterogeneous ventilation. In homogeneous ventilation, the entire lung participates in ventilation. The lungs can handle large amounts of pressure when homogeneous ventilation is happening. But in heterogeneous ventilation, this attalec trauma is damaging the lungs. In ARDS, we have large amounts of lung that are not participating in gas exchange. Lots of these H areas. That H area will spread as ARDS spread. So if you have 60% of your lungs is not participating in ventilation, well, that means that you have to get the remaining 40% to make up for the amount of lung that's damaged. So you increase the rate, which means that you have to increase the spread of bad lung. And so the spread increases, and you can see how that makes for a lot of stress and strain. So that was attalec trauma. Now I'm going to get into biotrauma. When we talk about biotrauma, we're talking about the damage to the cells that the cells are inflicting upon the lungs. It's the body's own cells that are causing this damage. It's self-destructive. This graphic is from a really good article from the New England Journal. And this list really describes well how biotrauma works. First, you have your alveolar macrophages that come along to protect the lung and fight off invading pathogens. Then the cytokines come along and they promote the accumulation of neutrophils. It's the neutrophils that really cause the trouble in the lungs. These neutrophils have a side effect that will damage the lung tissue. When the neutrophils damage the lung tissue will allow flooding of the alveoli and interstitium. Then tumor necrosis factor causes intravascular platelet aggregation, microthrombi formation, and a hyaline membrane formation. What is a hyaline membrane? Do you know? When I was in school, I had some ideas, but I didn't really know for sure. I like to think of the hyaline membrane, well, have you ever had a sink full of dirty water? And then when that water drains, you have all that dirt at the bottom of the sink. That's kind of like what a hyaline membrane is, except that it's happening while the sink is still full. A hyaline membrane is basically a layer of cellular waste and dead cells that clump inside the alveoli. You know how your AC membrane is really, really thin, right? Well, with this cellular garbage coating the AC membrane, the air can't pass through. When you have a hyaline membrane layer, you will be able to tell because the patient will have diffuse alveolar damage, or DAD. And if that has occurred, then the patient's chances of survival drop significantly. If the patient has DAD, they're 5 times more likely to die from refractory hypoxemia. In patients who don't have DAD, they're twice as likely to die from shock. Here's another look at the hyaline membrane. In the first picture, you can see the inflammatory cells hanging out in the alveoli. You can see I'm pointing at them there with the black lines and the arrow. Then here in picture B, you can see how the alveoli are completely filled with this proteinaceous material. And this is a picture of pure shunt. Any blood going through here is not getting oxygenated at all. And if we were to look at picture C, well, here, if you are wondering why the picture is blue instead of red, that's because they use a different stain for this slide. But you can see that the longer, thin cells in picture C, those are fibroblasts forming scar tissue. And when you have scar tissue, you have decreased compliance. And that takes us to the second hit, the proliferative phase, We just saw those fibroblasts, which are there for the creation of scar tissue. The creation of scar tissue is what the proliferative phase is all about. Here we see a lot of lung remodeling and scarring, and the result is long-term compliance decrease. The trouble is, we don't know who is going to end up in that proliferative phase. It seems like sort of a random thing, where some people are able to heal their lungs naturally and some are not. Now, let's get into the management of ARDS. I put this here, something that I read in a short little book when I was in RT school, reminding me that no disease is cured by a ventilator. Ventilators only stop diseases from getting worse. Okay, and here's another one I want to show you. This is a parable from ancient China. A lord in China once asked his physician, a member of a family of healers, which of them was most skilled in the art. The physician, whose reputation was such that his name became synonymous with medical science in China, replied, "My older brother sees the spirit of sickness and removes it before it takes shape, so his name does not get out of the house. My next older brother cures sickness when it is still extremely minute, so his name does not get out of the neighborhood. As for me, I puncture veins, prescribe potions, and massage skin, so that from time to time my name gets out and is heard among the lords." So sometimes the best healthcare practitioners remain anonymous and their skills unappreciated. But we're not here for glory. If you're here for glory, join the baseball team. Imagine how much heartache, struggle, and time is saved by stopping ARDS before it starts. Well, if you can do that, please let me know how. Andrews and colleagues described a small study where APRV was given to trauma patients who, due to their mechanism of injury, like smoke inhalation, near drowning, or penetrating chest injury, or so on, they were really likely to develop ARDS. These patients were ventilated with APRV, and of those patients, only 1.3% of them developed ARDS. Mortality rate among that 1.3% was only 3.9%. And death in all of those patients who died was due to mechanisms other than ARDS. So, do people have ARDS before it is actually manifested? Like before we can actually see it in chest x-rays, or before they even have shortness of breath? Well, maybe they do. I mean, some people suffer spinal cord injury, they're put on a ventilator, and they're on the vent for the rest of their lives, and they never get ARDS. Yet some people are put on a ventilator and develop ARDS within a day or two. Did they already have ARDS and we just didn't know how to detect it? No, if you find out, please let me know. Here's the next best option we have right now, ARDSNet. You probably already know about ARDSNet, but I'll just summarize it quickly. It's a method of ventilation that emphasizes two critical criteria: tidal volumes of 6 milliliters per kilogram, plateau pressures of 30 or less, and a stepwise approach to PEEP and FiO2 as seen by this chart. Should you use the high PEEP and low FiO2, or should you use the high FiO2 and low PEEP? Just go by what your physician says on this one. Actually, the studies show that the higher PEEP had a 28.5% mortality, while the higher FiO2 had a 32.8% mortality. However, the medical community generally accepts that they're both about the same as far as mortality, so either strategy is okay. We will pronate patients to increase survival. Proning is only done if the PF ratio is 150 or lower. The way this works is it helps to redistribute that proteinaceous fluid and cellular debris so that more of the lung can participate in ventilation. It really works well. There's a couple of things you have to worry about though. First, when you're turning the patient, you really have to watch out for those tubes, especially the ET tube. You've got to watch out that nothing gets pulled out while you're turning the patient. The other thing you really have to worry about is bed sores. The patient can get a lot of bed sores on his face, arms, knees, hips, but that's more the nurse's responsibility. But yeah, this is a pretty effective strategy. And next is permissive hypercapnia. This is a strategy where we will decrease ventilator support in favor of protecting the lungs from injury. This is something that we'll do in people who have very severe ARDS and they're not doing well. You may get a little nervous about letting the CO2 rise to 60 or 70, but studies show that this is actually well tolerated and will actually increase diaphragmatic strength. Just remember that you can't do this in elevated intracranial pressures, because in patients with elevated intracranial pressures, it will increase the intracranial pressure even higher than it already is. Okay? So as we wrap it up, I'm just going to go over a few things that we talked about. ARDS is recognized by bilateral fluffy white opacities. If there are cardiac factors involved, then it's not ARDS. And if the problem has been going on for more than a week, it's not ARDS. You can calculate a PF ratio to determine the severity of the ARDS. There are three main mechanisms that are causing damage in ARDS: volutrauma, atelectrauma, and biotrauma. With ARDS patients, a low PaO2 or a high oxygen requirement will determine the severity of ARDS, but a high CO2 is also often seen and is also indicative of severe ARDS. The treatment of choice is ARDSNet, and everything pretty much revolves around ARDSNet. Proning has been shown to reduce mortality and to obviate the use of more aggressive settings. Permissive hypercapnia is the strategy of sacrificing good blood gases in favor of lung protective strategy. So with that, I want to thank you for your attention. I hope this helps your understanding with ARDS. And if you have any questions, here's my phone number, and my references are coming up in just a second. Thank you again for your attention.